Okay, I'm Dave Uhlman. I'm the CEO of ClearHealth, and we're one of the larger, or maybe the largest, open source practice management EMR vendors that's out there today. Our system's under the GPL. We do some very large facilities, some networks across the nation. We've been doing it for 7-8 years now. What I'm here to talk about today is data mining in the what I'm calling the EMR gold rush. So if you follow legislation at all, which I'm sure some of you do, some of you don't, the government passed a lot of laws, 10,000 pages or so, many of which relate to electronic medical records. And what they're doing is essentially paying doctors to now implement and use EMR. And what this means for most of us is that a lot more data is going to become available in an electronic format in healthcare than ever before. And not in a little bit, but on a factor of 1,000. We're talking about hundreds and hundreds of terabytes of data that are now going to be available. What do we do with it? That's what I want to talk about today. Beer and diapers. That's the classic example of data mining. And it's a story that goes back a long time. You have a company, Walmart, let's say, and they start looking at their sales data, and they find that in late evenings or on weekends, men go into the store and they end up buying beer and diapers. And they draw a lot of conclusions from that. And so what they do is they change their merchandising to put the beer and the diapers in a more convenient place, and the sales go through the roof. So that's kind of the classic myth about data mining. In reality, there's not a lot of truth to that story. About 20 years ago, OSCON did some analysis and found that some of the time in those periods, some people, they don't know who, purchased beer and diapers together, but they never changed their merchandising, anything else, but it's one of these long-lived myths in data mining. So what data mining really is just taking this wide expanse of data that you have available, introspecting it, looking at it, reporting on it in different ways to try and find information that you may not have been able to see before, and to try and correlate pieces of information that are not easy for a person to sit down, look at in front of them, and make correlations just using our own eyes and ears and brains to do. When you're doing data mining, what you're trying to do is create a question about a particular situation that then you can go and you can track down the why. So data mining is itself not a system you're going to use to answer the why question. It's about creating new questions to then pursue. So that's a difference from, say, just reporting, where I'm trying to say, how many visits did we do last year, how many, so on and so forth. When you already have that level of understanding about what you're asking and the results you're looking for, it probably isn't data mining that are the right tools to use. That's more of a standard reporting case. When you don't know what you don't know, the so-called unknown unknowns, that's an appropriate scenario for data mining. It's an important distinction because the tools are much more oriented towards one of those cases rather than the other. When we look at our own customers and our own patients that are in their systems, we have almost 8 million now. We predict that over the next 7 years, we're looking at from today where a practice may only create 1 kilobyte of information, just a few pages about each patient, to an enormous multiplying effect over the next set of years, where for every year you're a patient at a healthcare facility, there might be 250 megabytes of data on average. And so what do we do with that? That's just a tremendous, you're talking about things like imaging, visit records, narrative, pictures of acute conditions, lab results, so go on and on and on. And as medical technology continues to advance, the types of imaging, the types of tests we can do keep multiplying. We're looking at, a lot of the talks here had touched on some of the data collection that can be done from patients. So now you're looking at maybe a patient every day having monitoring of their blood pressure, what they eat, what they don't eat, all that adding up just continually to this enormous, enormous mountain of information. And right now, medicine is in the Stone Age in terms of the tools it uses to analyze and to create good conclusions out of that data. Medicine has a weird split personality to it. On one end, some of the most bleeding edge, cutting edge research that's done in any industry is done in healthcare, is done in medicine, all the way into genes and DNA and so forth. And then on the other end of the scale, you have 700,000 doctors every day going and sitting down with a patient in an exam room and recording on paper in a basically unstructured format, maybe using stick-it notes, about your general health. And what I think the government hopes as part of this incentive program, and what some of these tools can do, is shift that balance a little bit so that the physician who's treating an individual patient in an individual exam room can use some of these powerful tools that 10 or 20 years ago took a supercomputer to do. They can sit on their desktop and they can actually analyze a mountain of data for you as an individual patient, and then they can look at a population of theirs, not the whole nation, but just their group of patients, and draw conclusions from that. We're going to look at some of the tools today to do that. One of the other important points about this meaningful use is one of the guidelines requires that you enable electronic access for a patient to access their records in an online manner. It doesn't specifically prescribe how they have to do that, just somehow, but it basically means that what has been kind of a nascent attempt, a nascent effort at patient portals is going to become an onslaught where everybody's going to have their own different thing. There's Google Health, there's HealthVault, there's all these out there. On one hand, I think it's very good because we are going to start to get a lot more information and be able to create new sets of conclusions and diagnosis and tools that we haven't had before. The bad side is that right now the standards are virtually non-existent. It's just going to be piles of messy, tough to analyze data. Here's a picture of our patient portal itself on an iPad. So within 2 years, it's very likely that most of the practices you go to, you're going to be handed an iPad, you're going to be set at a kiosk, you're going to be doing all those things and being able to collect your demographics, your insurance information, your patient history. But there's actually a lot when we talk about data mining that's secret data or hidden data. So when I sit you as a patient down in front of something like this patient portal, there's the obvious that I'm collecting here. I'm collecting just your name and your date of birth and your gender. But actually, at the time that you're using the computer, much like Google and some of these other organizations do, I can learn a lot about you from how you use the mouse, simply from how you interact with the computer. So it's important in data mining to understand that there's the obvious data points, things that you might be familiar with, but there's the equally valuable, somewhat hidden data points about how you as a patient, I can now correlate your gender, your age, your name, your last name, with your ability to use the computer. If you hesitate to answer a question, that itself may be relevant information about that particular question. Medical information can be extremely sensitive. Obviously, a medical record contains, in most cases, perhaps the most detailed record that anyone has about you, your life, your history, your relationships, all of those things. We have a law called HIPAA. HIPAA protects in a broad way a lot of this information. HIPAA never envisioned some of the things we're talking about here today, kind of the Google level of data analysis. It just that wasn't conceived of at the time that HIPAA was written. So there is going to be, I think, a serious set of discussions that has to happen, and unfortunately some abuses that are probably going to occur before we reach a better consensus on how privacy and private information is treated and handled. In data mining, as I said, it's a very expansive way to look at information. Trying to fit that into a presentation, trying to nail that down can be difficult. I wanted to give everyone very specific examples and very specific tools about how we have used it, the conclusions we've been able to see, and kind of work backwards from these questions so that you can then extrapolate for your own cases how to use these tools and the scenarios you can use these tools. One of the number one questions we always come across in rolling out an EMR is that a physician is time limited, and they want to know, how can I get at a glance a very good understanding of this patient's overall health? From a general practitioner who might only see 15 patients a day, say an oncologist who could see upwards of 70 patients a day. It's not possible for these doctors generally to have crystallized in their brain your entire health history. A lot of doctors are very good at knowing you as a patient, kind of keeping a mental track of the basics. But as your chart expands to 300 or 500 or 700 pages, there's just no way they can keep that all upstairs at once. So we've created something we call a horizon graph. And this is data mining in the sense of we take this large data set you have and we use visualization to find some of the distinctive patterns and the exceptions that may be present in that data. And I think when we talk about data mining, there's sort of the back-end retail financial aspects. In healthcare, most of the benefits that we see coming out of it, most of what I'm going to talk about in this presentation today, are doing data mining using visualization as a tool to find those patterns. There are certainly very large-scale things you could do if you were the National Library of Medicine or things like that to find national trends At an individual physician level, at a facility level, I think visualization is some of the best tools you can use to find these distinctive patterns and so forth. We'll talk about some of those underlying algorithmic ways to find patterns, but we're going to talk primarily about visualization here. So in this chart, what we have is a 3D axis of time. So the further away I see something, the longer ago it happened. The more recent I see something, the closer it is to me. And I'll see if I can, I guess that's okay. So each of these colored lines represent a particular axis of either labs, meds, problems, the visit dates, so forth, things like that. And this is a static picture. In the application, I can interact with this graph, and I can move forward or backwards in time, and I can highlight these rings, which represent particular visit dates. So here, I've taken what is normally data structured in, in the paper world, it's going to be these flow sheets, literally just grids that are filled out almost like a spreadsheet, 1, 2, 3, 4, with your vitals, your labs, all that. A doctor looks at that in a very flat way. And I brought it into a three-dimensional space. I've colorized it. I've presented an interactive level where I can move through time and I can transition through some of these different types of data points. And I can see at a glance a lot of information. I can also see patterns emerge very easily by looking for clusters of color and clusters of these dots that are on time. So that's an interesting example about how to take what's a very common practice in healthcare, bring it into a dating mining context on an individual patient, and present a visualization that to a human being, it's very easy to pick out those patterns that it can appear before you. One of the things that historically open source and open source technologies have not been particularly strong on is aesthetics. So I feel a little bit lucky today in that most of the other products and tools we're going to look at actually are very strong in aesthetics, perhaps better than many of the proprietary counterparts. So we have a little bit of eye candy coming up, and I think that says a lot about where open source is today overall. In this question, we're talking about the PUBMED data source. So PUBMED is put together by the National Institute of Health. It is a huge, comprehensive warehouse of research and publications that have been done about pretty much every medical disease that has ever received federal funding. Sometimes abstract, sometimes more detailed analysis, so forth, so on. The problem is this enormous data set. How does it relate to me as an individual physician and you as an individual patient? It's a hard thing. There's no way a physician can sit down with you in the room and start thumbing through it. They have an interactive website where you can search, but it's not that easy to relate all of your conditions with maybe something deeply buried in there. Maybe you have a more unusual illness. How do I find out all of the research and everything that I should be pursuing about that for you? This is where we talk about one of the back-end technologies that can help support data mining, something called a neural net. And this could be a talk in and of itself. There's a particular open source library called FAN, which is a great technology to use to analyze this information. A neural net, put very simply, is a computer program that can perform matching in a very amorphous way. It's not a literal type of match. If some of you are familiar in programming with something called a regex or a string match, it's not that simple. It's not like I can say, well, if it contains the word diabetes, then I'm going to find that type of article. It performs a much deeper level analysis that's very good at finding previously unknown patterns. And so I can create, a tag cloud for a patient that contains keywords about all of their diagnoses or all of their medications. I can push that through a neural net filter and have it compare against all of the PubMed articles that have been previously put through that filter. And that neural net's going to produce for me a set of matches, a set of correlations between those keywords and those articles. And it can do so in a way that has a lot of tweaking available to it over time, particularly for the same patient population. You can continue to use this tool and it gets better and better accuracy. Facial recognition is something that's done a lot today. A lot of facial recognition tools ultimately use neural nets to try and perform that. And so that's a good example to try and understand the type of matching it does. Human beings are very good at this type of matching. I can look at two different faces and I can say, yeah, that's the same person or not. I might be able to do it even with two different photos 10 years apart. That's generally not something that a computer is good for. It's sort of on or off. The neural net allows that additional layer of analysis so that the computer can make essentially guesses about the probability that two things are the same. We're going to come back to neural nets a little bit later on. On the billing side, how do I estimate the amount of reimbursement that different payers may collectively make for a single encounter? So There's the fee schedules in healthcare. I know that contractually I'm supposed to get $80 for seeing you as a patient today and spending time with you, and I send these codes over to the payer. You might have more than one insurance. You might be on Medicare and Medicaid. One of the problems a practice has is that these insurance companies are essentially masters at figuring out ways to reduce the amount they're going to pay you. There's a very complex set of rules that they use. And so here's an example where data mining can look at historical behavior as well as the unique parameters of today's visit and produce for you a graph about who's likely to pay how much, and taking into account the interactions between Medicare. If Medicare pays you a certain amount, Medicaid's going to pay you a different amount based on what Medicare paid you. Here's an example of using an InfoViz toolkit in JavaScript to graph for this single visit the type of relationship between whose dollars are going to come in. This InfoViz toolkit is a really good way to graph any of this type of data mining information that we're talking about today. There's a lot of different graphs and charts and styles that are available in it. Here's an example that we've used it for. This same graph could be used for structuring relationships in a family and illness, let's say. All of those things. So it's a really different type of approach to how this information is normally looked at. Again, a biller might look at it in an Excel, and they might make their best guess. This is allowing the computer to substitute some of its energy and efforts in predicting how these things are going to play out. The URL down here is also where you can see several examples of other charts and things that they offer. Another question, how to predict which patients will be late or not show up tomorrow. Very common problem in practices. I'm going to overbook my doctors with the understanding that a certain percentage of my patients won't be able to come in tomorrow. As a medical practice, if I am paying for the overhead, if I'm paying for all the doctors, and you don't show up, that's a lot of missed opportunity in terms of revenue and covering my overhead that I have. So this is very common practice, and it's typically done in a broad way. We say, how many no-shows did we have last year overall? Might be 10%, 20%, even in some practices 40 or 50%. So every day I'm going to overbook by that much. And this leads to the common problem in the waiting room. Why is it always late when I go to my doctor? I showed up on time, but he's late. That's why. Because they don't take into account unique factors. They're using this blanket analysis to do that. So if I take a technology like a neural net, I can take your particular parameters as a patient as well as the particular day, because obviously people immediately after a holiday are later than people in just any other day of the week. The natural behavior of humans fits into some broad patterns that a neural net can understand. And then I can use a stacked bar chart to show the likelihood of every patient who's going to show up tomorrow. And instead of saying across the board we're going to do 20% overbooking, I say for tomorrow, for these specific patients, we think there's a strong likelihood they're not going to show up. We're going to overbook only those slots. So it's a win-win for you as a patient, because now hopefully you're waiting less time. It's a win-win for the practice because they continue to keep their full capacity operating. How to analyze lab results simultaneously for a single patient. So you as a patient may get 6, 7, 10 tests done. Each of those tests might have 10, 20, 30 different results to them. Again, a doctor's just looking at it in a spreadsheet kind of way. They might have some charting, simple line graphs, things like that. But if you're, say, diabetic, or if you have hypertension or a lot of these complicating factors, there's several key parameters that I want to look at, and I want to look at them in relation to one another. Not a tool that a lot of physicians have in front of them today. You can use something like a STEAM graph. This is from ProtoViz. It's a Stanford-based infographic or information visualization toolkit, again in JavaScript. And so I can layer on top of one another different peaks and valleys regarding the performance of, say, your HDL cholesterol, your LDL cholesterol. And by using scaling, I can put many different things within the same chart at once. So I can see here you have a huge peak in all of your vitals, let's say. So what is that related to? As I'm interacting with a patient, I can connect all of these different dots together. Allows me to perform better care for you in a much faster way than I have been able to in the past. Another example that is very common in community health centers, federally qualified health centers. These are the types of facilities that provide care regardless of your ability to pay. In exchange for that, the federal government gives you a little bit of a benefit on your reimbursements, so you get paid a little bit more by Medicare. But you have to, in this sort of deal with the devil, you have to provide an enormous amount of end-of-year reporting. And that report is something that brings most community health centers almost to their knees, because they're literally taking people, they're going out They're looking and counting each individual chart that they have. They're taking those numbers, they're tallying them up on a little sheet of paper, and then creating these big aggregate numbers out of all of that. It can take weeks to put this together. Now that you've got these EMRs running, you have the data that you can put on that form to the federal government very easy, but now that you've gone to the trouble and the government's gone to the trouble to decide about what data points are important, all of these different things, why not use the data yourself as a practice to help you understand your own operations? That way there's a win-win scenario on the UDS. You're not just doing it to fulfill your legal requirements, you also get some analysis out of it as well. Here's a wheel graph that we offer about staffing and utilization. Using this, I can represent color and tree type information in a very eye-friendly way. And I can say, was I overstaffed for the year? Was I understaffed for the year? Was my allocation of doctors versus mid-levels versus physician assistants the best fit for the patient population we have and the types of encounters that we had? So that's the information that today is it's just not looked at in medical practices overall. How does geography impact patient wellness? Well, most of us can use Google Maps now to figure out what restaurant we're going to go to, everything else. It's time that healthcare started playing a little bit more information about their individual patients, their individual patient population, and how that health relates to this. This is some fictitious data. Obviously, I can't put real patients on a real map for a presentation here, but it's a new way of thinking. Doctors can use a lot of this information to help understand very local health. So normally we talk about these national trends. This is going to be a bad national flu season, things like that. Well, that's fine, but that doesn't help you as a practice in San Diego or you as a practice in Boston. You want to look at your microcosm, your individual area, and the patterns that can emerge on a very local level that affect your specific patients. Google Maps is just a phenomenal tool to do that. It makes it very easy to tie this information together. One of the things about data mining that I talked about earlier is the unknown unknowns. So I have all this information. I don't know what questions I want to be asking. How can I just search arbitrarily for patterns that may emerge and then go off and look at those in more detail? Here's where we can take a neural net technology, which we talked about. Again, this sort of not fuzzy matching, but non-deterministic matching. And we can take something called a genetic algorithm. Genetic algorithm is a representation in a computer of very much the process of natural selection that occurs in nature. You set a couple of broad parameters, and you let the computer iterate over those parameters until it finds the best possible match for the parameters that you've set. In the graphic here on the right, what we see is the Mona Lisa. So someone decided they were going to take the Mona Lisa and using triangles and a very limited set of colors, use a genetic algorithm to reconstruct an image that looks as close to the Mona Lisa as possible, but takes up much less space than a regular type of JPEG or type of image would happen. And you can see, step by step, the leaps that the computer made using this genetic algorithm. So it tried one thing, it compared it to the original Mona Lisa, it found what worked, essentially the genes about those triangles that it wanted to keep that were a good fit, and then it iterated to change the rest of it to try and get closer. And over the course of about 100 tries, down in the bottom there, we have a pretty good approximation of the Mona Lisa using much less, many fewer data points to represent it than if it was just a bitmap type of image like your digital camera would take. This is a perfect combination with a technology like the neural net to take your huge information warehouse where you've got all your labs, all your diagnoses, your billing information, and find arbitrary patterns. Because what I can set up in the neural net is a basic match. That match could be, I want to find a cluster of at least 50 occurrences of anything. Doesn't matter what it is. You can set it to whatever level you feel comfortable based on your level of transactions. And using a genetic algorithm, I can continue to tweak that neural net to try and find for me these interesting correlations of data that make a mountain. And so that's a capability that just it's never really even been done on a small practice or medium practice, even a large-scale practice scale. And now it's trivial to do with these open source tools. I can download it in one weekend. I can come up with entirely new avenues of pursuit into the data that we have about patients. It's a very exciting set of things to begin looking at. It's unexplored frontier for the most part. There's not a lot of that left. How to analyze diagnoses in a patient population overall. So in the news, we constantly hear about, let's say, diabetes asthma, hypertension, high blood pressure, these common illnesses that are the chronic diseases that are the most expensive, sort of the primary focus of a lot of healthcare attention and dollars. We hear that a lot, but how do we know that that's really true? Well, we're going to look in detail at one of my favorite tools, probably my favorite tool overall that I've found, called Gephi, which is a real-time visualization of any data that you want. Here we're going to look at actually a real practices set of data. It's all anonymized. It's a patient population of about 50,000 people. We're going to look at their diagnoses. So you can see right here at a zoom-out view, the cloud. This is a social network graph. So dots that represent diagnoses are larger the more times those occur within your patient population. And there's a line representing the connections between all of these different diagnoses. So we can look at a video here of the rendering of this. So here's our raw cloud of dots. This is the sort of forced formation that'll happen. And I can play this video. Unfortunately, my little airbook here is not quite powerful enough to show it. People know that healthcare is complicated. This is how complicated it is. This is one practice set of patients. And you look at the number of diagnoses they have overall, the size of those, it's an astounding level of complexity. And this graph I'm showing mostly for effect, just to show you the scale of a single practice. Not the whole nation, not anything else, just one practice. This is how complicated it is. We can now take these same tools and we can look at more detail. What are these dots representing? I can zoom way in. So I have my PDF here. Here's the same information graphed the same way. Well, there we go. We see it firsthand. Let me zoom out here. What are our biggest dots? Well, here you go. You got benign hypertension, high blood pressure. You've got diabetes. You've got sore throat. So you can see that in a way that the raw data, I mean, you can count those things up. You say, okay, yeah, that's sort of the top of the list. But this shows you firsthand how those illnesses relate and what your practice is doing when patients come in. Here's a little bit better view. And you can just see the variety of illnesses that we as humans have. We hear in the news about these 4 things, and sure, that's true. Those are the most prevalent. But clearly from this, we can see that there's a lot of other complicating factors. And those complicating factors, what make each of us unique, what make healthcare such a difficult problem from an IT standpoint. And I'll finish up here with one more view of this information. Again, using the Gephi tool, constructing this out of a pretty simple data set report we put together in a few minutes. I can zoom out and I can render in 3D what this looks like. So you can see these big dots are these diabetes, hypertension, so forth, so on. So again, that complexity is just a single medical practice. It's an astounding fact when you view it like that. So that's all we have for today. Those tools are what we've found to be the best available. There's an infinite number of ways you can connect the dots on all of those. And in terms of visualizations, there's some of the most advanced technology out there. They're all open source, freely available. Thanks very much, and I hope to see you again next year at OSCON. Are there any questions? Sure.
What's the most compelling example where you've seen a visualization actually deployed and used by doctors to improve delivery of care at either clinic level or hospital level?
Sure. The one that really, like I said, is our sort of number one question is this one here, this horizon visualization, which is where in every visit, every day, every doctor confronts this problem. You've got your labs, you've got your meds, you've got your existing problems, your patient history, what's happening now, and how do I get that into my head just before I see you as quickly as possible? And this graph is a very easy way to do it. If you're a new patient, there's really just going to be one ring, and it's going to be patently obvious to me that we don't have a lot of history for you. If you're a patient you've seen for 8 years, this tunnel is going to go way, way back, and I can quickly walk through it and see, well, what was your primary problem last year? What was it this year? Across all those axes.
And you have doctors using that now?
Yeah. And it'll be in our open source release pretty soon, as soon as we kind of nailed down. It's information overload. What's the right balance between these lines? How many lines are important? How many lines are not important? Getting doctors to agree on anything like that is a challenging endeavor.
Do you have any doctors get vertigo looking
Not yet, but I wouldn't be surprised when we roll it out full. Doctors are usually pretty good at voicing their opinions about these sorts of things. So, yes?
For use with the clinical environment, to what extent have you validated these things with clinicians?
When you say validate, what do you mean?
Well,
You mean, do we deploy them with physicians, or do we?
How do you ensure the usability meet typical clinical requirements?
I think that's what you just said right there. Typical clinical requirements are probably the most ambiguous type of definition you could make about healthcare. You can have physicians in the same building that'll do it completely differently. We do work very closely with real environments for physicians to drive, using their own feedback, how they want to view this information. This graph, for example, is a direct result of our physicians providing us with feedback and saying, here's our problem, here's what we'd like to be able to do, here's some theories about how to do that, what can you put together? And then we'll roll that out on a very small basis with some of the facilities we've worked with for a very long time so that they can begin to experiment with it. And then once everyone has a certain level of comfort with it, we'll begin making that available to the rest of our customers. It's a tool in the toolbox. We don't sort of force anyone to use it. It's not a default mode of operation. Again, it's just a data visualization, just like any type of reporting you might do. This is really just a 3D view of the flow sheet that almost all facilities use now today.
I mean, has it been subjected to research with?
No, this is not part of a clinical trial or anything like that. I mean, certainly that can happen soon, hopefully. Some folks will do that, but this is at that sort of front line of healthcare where the doctor's in the exam with a single patient. Okay, great. Well, our information is at the end of this presentation here, and so feel free to email us or visit our website. And hopefully I've left enough time here for you all to catch your planes.